Hello and welcome to Pediatrics Case of the Day. My name is Brandon Brown. I'm a pediatric radiologist at Riley Hospital for Children at Indiana University School of Medicine. We have a neonatal case today with a history of failure to pass meconium. Here's the newborn KUB. We can see some dilated loops of bowel which are abnormally centered in the mid-abdomen. And it's worth noting there's no gas seen in the rectum. So we follow this up, and we have, at day 2 of life, another KUB with more of the same, increasing dilation, no rectal gas, and now this more conspicuous finding marked by the red arrow in the right abdomen, showing these vague densities. They're a little obscured by a posterior rib, and we need to recognize those because they're important clues as to what's been going on with this patient prenatally. Now, anytime there's a history of failure to pass meconium, after a while, you can expect to see an order for a contrast enema. Here's our contrast enema to further evaluate that, and you can see cystographin refluxed back through the colon and into the distal small bowel, and the most immediate finding is a uniformly narrow caliber of the colon. Sometimes we'll refer to that as a microcolon, but here it's really challenging to see the difference between large and small bowel just based on size. We can also see multiple filling defects, a few down in the sigmoid region, but many more proximally in the colon and in the distal small bowel. Now, the other finding we have here that is more of a absence is this lucency over the vague lucency over the mid-abdomen, which is that gas-filled dilated bowel that we saw on the KUBs that we were following. So this is an area we did not reach with our enema. The contrast is not able to be refluxed that high, which means the transition between that dilated bowel and our narrow bowel is not being visualized. There's something else going on proximally that we haven't figured out yet. Here's our post-enema KUB showing those ever-increasing loops in the mid-abdomen. Clearly, our contrast didn't get to that point. And this goes on where multiple enemas are ordered, trying to refine the diagnosis. None of them are ever able to reach that dilated bowel, with the KUBs continuing to show increasing distension. Now, as an aside, I should mention here that cystographin is the enema that we used for our diagnostic study at the beginning of this case, but there is support in the literature for using higher osmolality contrast agents like gastrographin, dilated 2-to-1 or 3-to-1 with normal saline, in order to try to draw more water into the bowel and loosen up those obstructing plugs and help the patient pass them. The idea is you can avoid surgery, and that's obviously of benefit. The downside is you're drawing water out of the plasma volume. So if you have a sick patient, somebody with tenuous pressures, that can be a risky endeavor, and it may require fluid resuscitation after the enema. It may not even be a good idea in complicated patients, but it has been shown to be successful in some cases. We were not able to reduce this obstruction just based on our enemas, and the patient did have to go to surgery, and at surgical diagnosis they confirmed what we had suspected, which was a case of meconium ileus. But not just isolated meconium ileus, this was a complicated case. So recall that meconium ileus is very highly associated with cystic fibrosis, and the problem there is abnormal chloride transport, where not enough water is being drawn into the meconium. It becomes thick and sticky, it obstructs usually the distal small bowel, and the secondary factor here is the ways in which it can become complicated, which is exactly what happened in our case. So in many, many cases, you can have a volvulus secondary to the obstructing plugs, you can have a concurrent jejunoileal atresia, and you can have cases of perforation where the pressure that builds in the upstream bowel behind the obstruction eventually decompresses into the peritoneal space. So ours is a case of meconium ileus with that perforation. Here you can see a coronal T2-weighted fetal MRI image showing that even prenatally there were obstructed loops of bowel. You can see the lumen here in all of these loops on this MRI is filled with intermediate signal intensity material. That should be brighter. It should be closer to amniotic fluid signal because that's what it is, swallowed amniotic fluid. But this is fluid that's been sitting in obstructed bowel for quite some time. You can see the brighter triangles of ascites surrounding some of those loops of bowel. So we know that this obstruction was present prenatally. We know it must have built up pressure and decompressed with meconium spilling into the peritoneal space, inducing an inflammatory response which ultimately calcified. But then we know that that perforation must have sealed up again because we've reaccumulated pressure. As the KUB shows, those bowel loops are definitely distended again. And so we know that this is not a straightforward case. This is meconium ileus with a history of perforation, but also there's a third component here. There's a concurrent higher atresia. So with cystic fibrosis, it's really important to remember that you can have uncomplicated cases of meconium ileus or just an isolated atresia, but then there's these combination cases where you get 2 or 3 things going on, and that's exactly what happened with our patient. So we were never going to be able to reflux contrast backward into those dilated loops because there was an atretic portion of the bowel there. Just to compare the enema in our patient with an enema in a patient with an isolated atresia, you can see that the abrupt termination of contrast doesn't really show a lot of plugs. In fact, this may even be a colonic atresia rather than a true ileal atresia. But the idea is that despite multiple attempts, you're never going to reflux higher. You're not going to see plugs to the same degree. And it can be challenging on the first enema to distinguish between these two diagnoses. And it may take 2 or even 3 enemas of repeatedly demonstrating an abrupt termination, a failure to reflux, before you start to feel confident that it's not just technique, it's not just inability to reflux because of an uncooperative patient. So don't feel as though you have to make the definitive distinction between these two things on the very first attempt. The surgeons will often want to repeat the enema. Here I've just compared meconium ileus with a similar sounding diagnosis of meconium plug, which is really not similar in terms of pathophysiology, but you can just immediately see that there's not a microcolon with meconium plug, it's more of a small left colon. And the filling defects themselves, they're pretty subtle here, but they're in the distal colon, and they tend to be longer and involve sort of these long stretches in the sigmoid region. And those are plugs that we're able to reduce usually through our enemas. It would be very rare for a meconium plug patient to go to surgery. Not nearly as many complications as meconium ileus. Just to wrap up, the key features that we're looking for to make the diagnosis of meconium ileus, we want to see that microcolon because everything has been obstructed in the region of the distal small bowel. And we're expecting the filling defects to be shown much more proximally. So we're looking for them in the colon, back in the ascending colon and the distal small bowel. And also bear in mind that your first attempt at refluxing contrast may not be successful, but it can take a couple of attempts to distinguish between an isolated atresia, an isolated meconium ileus. But importantly, remember that there are combination cases. So you can have atresia and meconium ileus, or meconium ileus and volvulus, and also look for that evidence of perforation as well. Thanks very much for tuning in. Please remember to check out the Case of the Day files for Indiana University on Twitter and also on Facebook.